well, good evening, everybody. My name is Jason Savage from the Cleveland Clinic, and I'd like to welcome you to tonight's AO Spine North America webinar on adult spinal deformity. I want to thank everyone from AO North America for the opportunity to put this webinar on, and obviously thanks to the two faculty members who are going to join me. So before we kind of get into the talks, I'd just like to introduce these two guys, two of my closest friends in the spine world, Ray Hoff from USC and Brandon Lawrence from the University of Utah. So thanks, guys, so much for taking the time out of your schedules to do this with me. And obviously, thank you to all of you for taking the time out of your night to join us. So just a couple housekeeping kind of things before we really get into the meat of the webinar. These are all of our disclosures. I'm sure we're all going to have them in our individual talks as well. None of these disclosures are really relevant to any of the content that is in any of our talks. This is just kind of the AO content validation statement. So I'll kind of go ahead and read this. AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. Does not endorse nor promote the use of any product, service of commercial entities. So just a brief overview, this webinar is really to discuss the treatment of adult spinal deformity. It's going to review some of the importance of preoperative planning, risk factors and prevention strategies for proximal junctional kyphosis and failure, and the role of hyper-lordotic ALIF cages in the treatment of sagittal plane deformity. Just some of the learning objectives that we're going to try to go over throughout this webinar over the next hour. This is really kind of just a tentative kind of agenda. I'm going to start things off by talking a little bit about complete versus limited correction in adult spinal deformity. And then Ray Ha is going to take it over and talk about risk factors for prevention strategies for proximal junctional failure. And then Brandon Lawrence, who's actually completing a deformity surgery right now in the ER, but he assured us that he will be available to give his talk on the role of hyper-lordotic ALIF cages. And we should have time for maybe another case presentation or two, and then obviously discussion. Just some upcoming events for AO Spine North America. So please kind of put these in your calendar. And yeah, so we'll go ahead and kick it off. Give me 1 second here because I gotta kind of share a different screen and get my talk up. Let's see here. Let's see. Hey, Chris, can you confirm that you're seeing this?
It looks good, Jason.
All right, thanks a lot. Sorry about that. I wasn't sure if I saw the right thing or not. There we go. Okay, so we're going to take kind of what I kind of call a 30,000-foot view kind of on this topic on adult spinal deformity, and really kind of look at, when she be considering, complete or, deformity correction versus when she be considering something smaller or a limited correction procedure. These are my disclosures, none of which are relevant to the contents of this talk. And I know Ray has kind of seen this image before, but, sometimes as deformity surgeons, we kind of use this go big or go home as our mantra. But I constantly tell our residents and fellows in Cleveland that, that's definitely not true for every case. And I think that's kind of hopefully the meat and potatoes of this webinar. This sweatshirt is actually something my 11-year-old daughter kind of made at a very non-competitive swim meet last summer. And I kind of thought it was funny because she chose these 3 stickers, and one of them was go home or go big or go home, which I was really proud of. And one of them was eat my bubbles, which is usually what I tell Ray when we're playing golf together. So, but the reality is that, the population age 65 and over is projected to double by the year 2050. And for the first time, at least in US history, older adults are projected to outnumber children. It's estimated that about 30 to 50% of these individuals develop a degenerative scoliosis. Now, most of these patients live very kind of healthy, active lives and don't have any significant issues as a result of their curves. But some of these patients, and probably a decent set of these patients, develop significant pain and disability that's associated with their adult spinal deformity. This is a really common problem, right? So people on this call, I'm sure, I know Ray and Brandon, we see patients who kind of come into our clinic with x-rays that look like this every day, right? And I think it's just getting more common as the population ages. And kind of when you sit back and think about, all right, do we need to do a deformity correction on this patient, or can we do something smaller? I think we should always be thinking about, can we do something smaller? in this adult deformity patient population, I kind of think of three things, or four things, sorry. Is there a clinically significant deformity? Is the patient complaining about a postural problem? If the patient is not complaining about having a difficult time standing up, oftentimes we can find something smaller to do to treat their underlying kind of symptoms. What are the symptoms, right? And what are the sites of neurologic compression? I think oftentimes that really dictates kind of what our treatment options are. What are the risks and benefits of surgery? What are the risks and benefits of a big surgery? What are the risks and benefits of a smaller surgery? And oftentimes those risks vary significantly. And then finally, if there is a patient that you see with a significant deformity problem, I think we have to really be honest with ourselves and can say to ourselves, can that patient tolerate a big operation, right? Because the last thing we want to do is put someone through a surgery that actually makes them worse at the end as opposed to better. Sometimes this is obvious. I think most of us or all of us on this call would kind of, see these x-rays, see a patient like this, and have a really long discussion with them about kind of what the options are. And I don't really think there's a small option to take care of something like this. This was a 65-year-old female who came in really just kind of incapacitated due to her inability to stand upright and her back pain associated with it, as well as her neurogenic claudication. And this person ended up undergoing a relatively big operation to kind of correct her deformity and to treat her stenosis symptoms. And sometimes these patients, even though they're some of the biggest operations we do, they really are happy as patients because they're so debilitated beforehand. But I would argue that most of the time we see these patients, in clinic for a deformity problem, it's not that obvious, and I see patients like this all the time who have a legitimate curve. Their overall posture is relatively well maintained, right? Their balance is relatively well maintained. And they've got like 2 or 3 level stenosis. And I kind of scratch my head a lot with this patient, kind of say, what would I do if this were me? What would I do if this were my mom or my dad, kind of with this problem? Would I offer them a large deformity correction surgery, a T10 of pelvis or whatnot? Or would I try to do something smaller just to kind of treat their underlying kind of degenerative problem that's causing their current symptoms? So, from a basic standpoint, and I think it's really helpful, and I still do this 12 years in a practice, I always ask myself, really 3 questions when I see patients. What are kind of the goals of surgery in this patient? What are the treatment options in my hands? And that's probably going to be different than a lot of other people. Ray and I are the closest of friends, as well as Brandon, and we probably all three of us do things very differently in terms of what our skill sets are. So, what's the best treatment option for that problem in your hands? And then I always ask this question too: what's the smallest surgery I can do that accomplishes, right, the goals of surgery? And I think that's really important. Um, I think everyone, obviously in North America, everyone worldwide, would consider that the COVID kind of, coronavirus pandemic was the largest probably pandemic of most of our lifetimes. And that's obvious, and it's affected all of our lives in our world. But I think a lot of us are kind of now starting to talk a little bit about this, what we call the T10 of pelvis epidemic. There's been an absolutely massive increase in long fusion constructs over the past 10 or 15 years. And this increase has been highest in patients over the age of 65. It's estimated that there's been a 460% increase in long segment fusion constructs over the past 10, 15 years. Now, part of I kind of ask myself, why? Why do I think this is true? And I don't know. This is just my opinion. There's no really good data on this. But my opinion is part of it is the population is aging, and as the population ages, there's going to be more patients who develop a significantly clinically significant deformity. But I think a lot of it too is that we kind of started playing number games, and these numbers are incredibly important. And I'm sure everyone on this call is familiar with all these kind of radiographic parameters that we look at now in this patient population. But I also think kind of we kind of lost our way a little bit, and we were kind of seeing and treating degenerative problems. But if there was a little bit of a mismatch between their pelvic incidence and their lumbar lordosis, people were getting bigger surgeries to kind of treat the X-rays as opposed to kind of treat the patients. And this is my hypothesis that we've seen an incredible increase in the amount of deformity surgery being done as kind of a result of this. But again, all of that stuff I think is critically important to kind of what we do and helping patients through these complex problems. I put this slide up here again. This is, lumbar lordosis index, which is basically just highlighting that most of our lordosis comes from the bottom of the lumbar spine, right? 60% comes from L4 to S1. And the reason why I put that up here is because I kind of like this notion of every operation is a deformity operation, right? We're either treating it, which is often the case. We're trying to prevent it by kind of paying attention to segmental alignment and maximizing kind of our lordosis at the segmental level. Or unfortunately, sometimes we're causing it. And I think as spine surgeons, we oftentimes sometimes cause more issues than we actually do help. Um, so what are some important things to consider? What's the patient complaining about? Obviously, I think that's probably the most important thing. Are they complaining of a lot of mechanical kind of axial settling back pain? Are they complaining of a lot of leg pain? Do they have a lot of neurogenic claudication? And are they complaining of a postural problem? And again, if patients are not complaining of a postural problem, it's rare that I'm kind of, thinking about putting them through or offering them a big kind of deformity correction, regardless of what their X-ray looks like. What do the imaging studies show? And I think this is important. The etiology of the curves, right? Is this an adult in their 50s and 60s with an idiopathic curve who's kind of lived with that curve their whole life? It is rare, or at least in my experience, really rare for the idiopathic curve to decompensate kind of later in life. So for that reason, it's really rare that I'm offering someone a big kind of deformity correction for idiopathic curve in adulthood. Oftentimes, those patients present with, a radiculopathy from their low lumbar fractional curve, and there's a relatively small operation that you can kind of, offer them to take care of that problem without putting them through a big, massive operation for something that they've lived with their whole life and usually have lived with fairly well. The de novo or the kind of the true degenerative scolies are different. Those are the ones that tend to or oftentimes decompensate and often lead to a postural problem. So what's the global alignment? What's the balance? What are the sites of neurologic compression? Are there significant comorbidities? I think that's really important if you're doing a fair amount of deformity surgery, like optimizing these patients prior to surgery. And we'll talk a little bit about that in a few seconds. And then what's your skill set? Not necessarily obviously kind of our surgical skill set, but what's your hospital set up for, right? These are operations that you should really kind of be doing, I think, at high volume centers who have, spinal deformity programs and perioperative kind of anesthesia protocols and optimization programs, because I think that really is almost as important than the surgery itself. So again, what are the goals of surgery? Is it a deformity problem? Is there a significant coronal or sagittal plane imbalance? If it is, then oftentimes, unfortunately, a bigger surgery probably is what that patient's going to benefit most from. Are they having a lot of settling pain throughout the day, mechanical pain? Do they fatigue easily because they're basically trying to compensate for their underlying deformity? And is there rib pelvic abutment kind of like, symptoms that are causing significant issues? If any of that stuff is part of the big symptomatology or problem, then I think, unfortunately, a small surgery oftentimes can't address those goals of surgery. And sometimes that's when or oftentimes that's when we're talking about deformity correction operations. Or is this a degenerative problem in someone who's got kind of a well-balanced curve? I think those are the patients that really benefit from short segment decompression fusions. And if we can avoid big surgery on those people, I think it's better for them. I think as surgeons, we have to be kind of very critical of our own kind of our own results. And I think, there's kind of three types of failures, so to speak. There's failure of planning, and that's really kind of big surgery for a small problem. I think we need to understand the age-appropriate alignment objectives and goals, and I know Ray's going to cover that in his PJF talk. And failure to modify or to address modifiable factors. Again, I think that's something that we really have to focus on, and we kind of have to be the quarterback or the leader of that part of the process, because we're the only ones who really understand the magnitude and the gravity of this surgery that we're putting these patients through. Failure of execution, and this is on us, I think, from a technical standpoint. Over and under correction is not a good thing. Handling of soft tissues, implant handling and choice, and then potentially choosing your wrong kind of levels for your upper instrumented vertebra. And sometimes it's bad luck too, unfortunately. Sometimes these complex surgeries, we think that we understand the problem and we execute it well, and they still have some issues. So I'm just going to run through a few cases here to hopefully highlight some of these kind of points. So this is case one. This is not a case of mine. This was done kind of elsewhere in the Northeast Ohio area, and it's a 67-year-old male who came in complaining of he had some back pain. He had really severe left leg pain. He had improvement with a left L5 selective nerve root block. And if you look at his X-rays, his overall coronal and sagittal balance is I think well maintained. If you look at the numbers kind of in detail. He's got a little bit of a PIL mismatch. He's got kind of this kind of flattening of his lumbar spine as a result of his multi-level degenerative disc disease. He's got a little bit of increased pelvic tilt, but really not that significant. He's a pretty kind of well balanced guy, and this is his MRI that shows pretty severe left L5 foraminal stenosis. He's got some 4-5 lateral recess stenosis, but really a bad L5 foraminal stenosis on the left-hand side. And this is kind of what this patient kind of had done. If you look at this goals of surgery, treatment options, this person ended up having a relatively big surgery. And I think he had a big surgery because the numbers kind of didn't line up. And I think there was a kind of a drive towards saying, okay, we need to kind of get this guy's lumbar lordosis closer to his pelvic incidence. And his leg pain went away after surgery, but I think a lot of us would probably argue that his leg pain could have went away after surgery with a much smaller operation, right? So this case two is a 60-year-old female who complains of severe leg pain, right greater than left. She's got a decent size kind of right or a lumbar curve, right? Sorry, I don't have her scoli films in here, but I'll tell you, she's well balanced. She actually stands up relatively well in clinic. These are x-rays. She's got a spondy at L4-5, and she's basically got one level of stenosis. She's got one level of stenosis at L4, L5. So again, and this is one of my patients, I kind of said to myself, well, what are the goals of surgery in this person? And what are the treatment options? And the goals in my mind for her were to treat her degenerative problem. She wasn't really having, she wasn't complaining of a postural issue, and she was complaining mostly of her leg pain. So we did a one level push lateral fusion, decompression push lateral fusion. This was 7 years ago. I saw this patient back in clinic last year for a neck problem, and she's still doing well, which somewhat shocks me, to be honest with you, but still doing well 7 years later after this one level push lateral fusion. So it just kind of shows that sometimes just kind of treating the small degenerative problem at that time may be the best option. Here's another case, 62-year-old female with severe back pain, left leg pain. Symptoms are worse with standing and walking. She works as a pharmacist, and she's got this pretty significant kind of thoracolumbar scoliosis. Her overall kind of coronal and sagittal balance are relatively well maintained, but she's got a lot of kind of rib pelvic abutment symptoms, and she's got a lot of left leg pain from this kind of lateral recess stenosis on the left at L4-5. Here's her CT scan. And kind of this one kind of was tricky for me because I really wanted to convince myself and convince her to do a small surgery just to treat L4-5. But the more I talked to her and the more I saw her, and I think I saw this patient 4 or 5 times before offering her surgery, before coming to a conclusion of what we were going to do, she was having a really difficult time standing up and working as a pharmacist. And she kind of had more axial kind of settling back pain and some rib kind of pelvic abutment symptoms. So this person, basically kind of convinced me after talking to her many times that I don't think a small surgery was going to work for her. I put this up here just really quickly because I think if you are going to be doing deformity surgery, you have to kind of be aware of this stuff. The medical optimization of these patients and the bone health optimization of these patients is incredibly important. And maybe we could talk about this in a discussion if there's time. So anyway, so this person ended up going through a relatively big operation. And unfortunately, she's done great. She actually went back to work as a pharmacist like 6 weeks later, which was somewhat shocking. But for me, after talking to this person for a long time, she convinced me that the small operation wasn't right. And then the last case I'll go over until we hand it over to Ray is a 64-year-old female with back and left leg pain, posterior thigh, calf, and she's kind of got this, relatively well balanced kind of lumbar curve that has stenosis at 2-3, 3-4, and worse at 4-5 with pretty significant foraminal stenosis at L4-5. And I kind of thought to myself, well, what are the goals of surgery in this lady? Is to kind of treat her neurologic problem and her neurologic symptoms. And I tried to avoid kind of doing something big on her. I didn't think she necessarily needed a postural correction surgery. I did this. So I did a 2-5 decompression fusion with a 4-5 TLIF to address her severe foraminal stenosis. And I thought this looked okay. And she did well for about 6 to 9 months. There's just one study I'll go through real quickly. And then she came back, unfortunately, relatively quickly and kind of failed. And she failed below it, and she failed above it. And she ended up needing another operation. And so then she ended up getting an extension up to T10 and down to the pelvis. So I'll kind of leave you with this. I think I kind of have 3 hopefully golden rules that I've learned over time. And then this is Mike Dobbs, who former president of SRS. I think he said this in an LSRS meeting, and I really think this is important. Having a PIL mismatch is not an indication to perform a big surgery. And I think that's true. I think all of those numbers and understanding alignment objectives is critically important to kind of being a deformity surgeon. But I think just having kind of a PIL mismatch does not mean that you should put someone through a big operation. This is Cliff Tribune, Ray Ha and I's mentor from Madison, Wisconsin, and he told me this one time: avoid fusing someone to the sacrum or pelvis like the plague. And it's interesting, right? Because we do a lot of fusions to the sacrum and pelvis, especially deformity surgeons. But I think there's way too many kind of L3 to S1s or L2 to pelvises being done for kind of degenerative problems. And in my mind, it's really symptomatic instability at 5-1. It's severe L5 frontal stenosis with a radic, and then it's obviously deformity correction operations that tend to kind of fuse someone down to the bottom. And then the last thing I'll leave you with, and I think this is really important, and it's helped me throughout my career. What would you recommend or do if it were your own family member, if your own mother, father, spouse, brother, or sister? And I think a lot of times, if you look at X-rays and look at a patient's problems, you probably wouldn't tell yourself that, yeah, I would never recommend a T4 to pelvis in my mother, unless they had a significant deformity issue, and you thought that that was the best option for them. So, with that, I'm going to kind of end. I'm going to stop sharing my screen, and I'm going to invite my good friend Ray to take it over from there.
Can you see the screen okay?
Yeah, it's perfect, Ray.
All good? Okay.
Yeah,
Thanks,
perfect.
Jason. Thank you to AO Spine North America for putting the webinar on. That was a great talk. I see that first case that you presented, and it's like a horror story. And I think, to be fair, for those of us who do deformity surgery, I think a lot of what deformity surgery is really taking degenerative problems and treating it appropriately so that you can prevent it, just as Jason said. Um, Certainly, with the rise of technically skilled surgeons, I think that we have encountered larger surgeries and more complex surgeries and more complex patients. And of course, one of the problems that have arisen alongside that is proximal junctional failure, which, if any of you have experienced, is can be quite devastating for the patients and for us as surgeons as well. And hopefully, I can shed some light into how we can prevent it and identifying risk factors. These are my disclosures, none of which are relevant to the topic at hand. We'll just go over the definition, classification. We'll go a little bit into risk factors and what the literature has to say about prevention strategies. The definition of proximal junctional kyphosis varies in the literature, but certainly most consistent would be greater or equal than a 10-degree change in your proximal sagittal angle. Proximal junctional failure being defined as PJK plus a structural failure of the UIV or UIV plus one, either vertebral body fracture, ligamentous failure, or both. And of course, accompanying pain, instability, neurologic injury, or need for revision. I thought this is a very nice definition of PJF, at least radiographically, is a proximal junctional angle of greater or equal than 28 degrees, or a change in the proximal junctional angle greater than 21 degrees. There have been several classifications in regards to PJK and PJF, namely the Boachi classification looking into disc, ligamentous failure versus bone failure versus implant bone failure. The grade indicating the severity of the angulation and the presence or absence of spondylolisthesis. And what they found was that type 2N, so bone failure without spondylolisthesis, was the most common mode of failure, although the patients who had the most devastating types of failures were the patients who had spondylolisthesis. So if you're watching a patient with PJK in your clinic and you start to see some spondylolisthesis, these are patients that you have to be very, very careful. Hart and ISSG also put together a severity score, PJF severity score, giving varying degrees of points for each of these characteristics. And there was excellent inter and intra-rater reliability, with higher scores correlating with a recommendation for revision. So it may help to guide some decision making. When looking at the literature, there have been well-defined risk factors for proximal junctional kyphosis as well as failure. Some of them seem obvious: age, osteoporosis, obesity, frailty, and greater preoperative sagittal malalignment, including greater amounts of SVA, greater PIL mismatch, or greater thoracic kyphosis. Uh, Maybe more recently is the question of whether distribution of lordosis and normative alignment and how that plays. And certainly fusion to the low lumbar sacrum, particularly pelvic fixation, as well as combined approaches have been associated with risks. This was just a study from the ISSG showing this uh, in 763 patients. They identified 6% of patients who had PJF, and that was PJK requiring reoperation. And again, these patients tended to be older, more frail, pelvic LIV, and larger degree of preoperative deformity and correction. Another interesting study by the ISSG looked at creating a model of different risk factors and determining in multivariate manner which ones contributed most significantly. And again, you can see in the order of importance: age, LIV, preoperative SVA, and then further down some of the other factors, particular UIV implant type. So as we look at these variables and then we start to go into risk or prevention, some of these are clearly non-modifiable and others are modifiable, and we'll have to kind of take each of these into account. So probably most important is an appropriate amount of correction, so obtaining optimal alignment. And a lot of work has been done on this, both understanding optimal alignment as well as achieving it intraoperatively. And then we look at prophylactic techniques with, let's say, implants, but that includes kind of soft landing principles: transitional rods, tethers, vertebroplasty, hooks at the UIV, and we'll delve into the literature a bit. I think we all know these numbers, and we all certainly kind of take these as our basis of understanding. But I do think that additional work has been done beyond just looking at these numbers and these targets. We know that as we age, normative alignment changes. And when you look at Schwab's study, which originally formulated these numbers, the average age was 50. And that's certainly very, very different than the average age of population that we may be treating. Certainly, my spinal deformity patients tend to be in the 60s to 75s, perhaps. So looking at Go Yoshida's study, they did a normative evaluation of asymptomatic patients with average age 70, so more like our patients. And again, these patients had an average C7 SVA of 5, which would be considered kind of in the deformity realm. And so looking into age adjustment, I think that this is an important factor, perhaps trying to obtain a relaxed amount of correction. And there's been some work done in this regard. But there's even been work done beyond this, and maybe one of the most interesting studies that I've looked at is the means study group led by Mike Kelly, looking at the T4L1 and hip axis, and just taking a look at, again, distributed lordosis based on different spinal pelvic anatomy. Whatever camp you fall in, whether the Rusili or gap score, or looking into kind of T4L1 hip axis or age adjustment, it's becoming clear that PILL is not sufficient. And I do think that we need to start taking a look into how we actually rebuild the shape of a spine to match what is a patient's norm. And that's a little bit beyond kind of the scope of this talk, but certainly something to consider. Jason mentioned this briefly. If you get a lumbar distribution index, which is kind of more mirrors the 2/3, 1/3, increasing L4 to S1 lordosis seem to be protective against mechanical failure in many different ways, both hardware failure as well as PJK and PJF. And so this is not only how do we, stop PJK and PJF, it's also how do we do degenerative surgeries more carefully, so that we can really prevent problems in the future as well. Just another series of studies kind of showing the same thing. This was a series of extended pedicle subtraction osteotomies at the L2 or L3 level, which we now would consider to be non-normative alignment. And if you take a look at the revision rates for PJK, they're very high in the teens, high rates of rod fracture mechanical failure. And then you contrast that to kind of a more recent study in which I think this mirrors more of the deformity world's practice, where we are moving the apex of lordosis back down, doing either L4 or even L5 PSOs. These patients had a much lower rate of revision for PJK as well as PJK in general. This may be controversial, but are some patients so at risk for PJK that we should not be selecting a lower thoracic UIV, even beyond kind of alignment? This study took a look at their risk factors for proximal junctional failure when the UIV was the lower thoracic spine. And what they found, if you had risk factor of age greater than 70, osteoporosis, as well as a proximal junctional angle of 0, they actually had 100% of those patients fail at the thoracolumbar UIV, which makes a case for should these patients be taken to the upper thoracic level to begin with, if they are at such high risk, to help mitigate some of that risk. It's tough to know. Maybe the most important study that I've seen recently, this again was from the ISSG. They took a look at whether prophylactic techniques were employed, as well as if the patients were well aligned or not well aligned. And what they found was that proximal junctional failure was lowest when the cohort was both well aligned and some form of implant prophylaxis had been used. And it was highest when the patients were overcorrected and had no implant. So there certainly is a marriage of the two. I think both are important. And that segues nicely into what are the actual prophylactic strategies. I think they either revolve around limited posterior tissue disruption or augmenting the posterior ligamentous complex versus supplementing the bone or providing a bit of a soft landing. And this was a nice review, taking a look at all the published techniques within the literature. You can see hooks there. You can see varying manners of tether. You can see vertebroplasty as well. So just kind of a bird's eye view, 7 studies for tethers. And what they found was that there was a significant difference in revision rates for PJK. 7 studies for vertebroplasty at the UIV and UIV +1. Also some statistically significant changes, although these studies were maybe a little bit lower quality. And transverse process hooks, not enough power to determine, but again, trends towards decreased revision rates. This was an interesting study looking at a more anatomic trajectory of the UIV screws. And what they found was that the UIV angle, if there was less than 3 degrees, meaning more anatomically positioned, it was associated with lower rates of PJK and PJF. Just anecdotally, I think one of the most important screw misses, perhaps, in deformity surgery is a laterally directed screw. So if initial passage is laterally directed, I think because you're breaking through the vertebral wall, that you're very, very high risk for fracture at the UIV. So just taking a look a little bit more into detail, this was the percutaneous vertebroplasty. There weren't any significant differences in PJK-F or fracture. There was perhaps a trend, but not statistically significant, towards less revision. And what they did find is it perhaps mitigated mitigated the speed of vertebral height loss. This was another study, just a case series, taking a look at 2-level vertebroplasty. And again, difficult to make any conclusions, but 28 percent rate of PJK with 5% acute PJF. Going on to uh, a little bit more recent concept. We all know that Hounsfield units has been important as a surrogate marker for osteoporosis. And this group and others have taken a look at if individual UIV Hounsfield unit can predict mechanical failure at that level. This study showed an inverse relationship with the severity of PJK, and they found a significant difference in their UIV Hounsfield units between the PJK and the non-PJK groups. So perhaps if you have a preoperative CT, you can do the relative Hounsfield units of each of your potential stop points, alignment and size of surgery aside, and potentially make a decision based on that as well. But more work needs to be done. Some of the strongest literature, I think, probably comes from tethers. I'll just go over 3 studies. This was out of UCSF, subsequent study out of UCSF, and also a study out of USC. And basically, all 3 studies showed similar things. If you augment the ligament versus not augment the ligament, your PJK rates are the same, but your PJF rates are significantly different. And this was our 6-month cohort. This cohort is now out to 2 years, and these results have remained true. So some kind of augmentation, I think, will limit your acute catastrophic failures. So in conclusion, prevention of proximal junctional kyphosis and failure is multifactorial. I think there's a lot of patient-related factors, getting back into pre-optimization, bone health, preoperative physical therapy, building up the muscle, nutrition, certainly surgical planning in terms of age-adjusted alignment goals, the apex of lordosis and UIV selection, and some sort of a surgical prophylactic technique, whichever one certainly you are most comfortable with. And with that, I will pass it on to Brandon.
Awesome. Thanks, Ray. Great talk. And I encourage, I see one question in the Q&A. We will get to that for sure. I encourage you to kind of put some comments and questions in. But without further ado, I'll turn it over to Brandon. Yeah, perfect, Brandon. We can see your slides perfectly.
Okay, perfect. Can you guys hear me?
Yeah, absolutely.
Do you want to address some of those questions now, or do you want me to get going?
No, go ahead. Yeah, go ahead, and then we'll whatever time we have left, we'll get the questions.
All right, great. Well, thank you guys. Thanks, Jason, for putting this together, and Reha for joining me as well. And that was the perfect kind of segue into some of the things that we think about in regard to balancing the lower part of the spine. Over the last 8-9 years, we've really transitioned to using hyper-lordotic ALIF cages, especially at L5S1, if we can get that disc space. And I think it's really helped decrease not only proximal junctional issues, but I think it's also helped with making that balance more distributed through that lumbar portion of the spine, especially the lower part of the spine. For me, these are my disclosures. I don't have any that are relevant to this talk. Special thanks to my fellow Parth Kathari, who helped put these slides together, as well as Matt Philippi, who's going to be joining Jason Savage next year in Cleveland. So we're psyched to have him there. So I'm just going to start with a case, and then we'll kind of get into some of the literature, get into some of the ways that I like to think about these problems. And so this is a patient. He's in his mid-60s who unfortunately had a string of surgery after surgery after surgery. And he presented to me looking like this, with hopes that the referring surgeon was thinking that I could maybe perform a VCR through the section that's still open, maybe in the sort of lower thoracic spine, or some other osteotomy that this patient would need, as he just continued to chase this patient sagittally for the last 5-6 years. And as we start to think about this patient, and I'll get into some of these slides, I won't belabor a lot of them because Reha did a very nice job of going through all this stuff. you know, really, this patient has a sagittal alignment problem. And when we think about hyper-lordotic cages, you know, we really think about them to address these sagittal alignment problems. And so, you know, this is the classic measurements with SVA, you know, and we really use the PI-LL mismatch to help us, you know, early on. But, you know, we've gotten into some other more sophisticated measurements that I think are a little bit more effective in, you know, helping us prognosticate whether or not these patients are going to, you know, have failures or not, be balanced or not, which can be a really challenging thing to do when we address these complex issues. And so, as you all know, you know, sagittal balance has you know, decreased function scores the higher the positive sagittal balance is, and increased disability scores, which you can see in table A and B here. Again, as sagittal balance increases. When we think about the spinal pelvic parameters, everything kind of drives off of pelvic incidence. I do like to use pelvic tilt a lot for me to really understand how decompensated patients are. You know, as they retrovert their pelvis and their pelvic tilt increases, they have more and more of a sagittal problem. And I have these cases are good examples of that. As we sort of think about pelvic incidence and we start thinking about the lumbar lordosis associated with it, you know, that's a great parameter to sort of set some guidelines. But I think as we sort of get into the pelvic tilt and really understand some of the key compensatory mechanisms as well, you know, with pelvic retroversion, as I already discussed, you really start to think about the whole spine, and you start looking at these compensatory mechanisms that you can see on this slide here. You know, and not only do you start to get this retroversion of the pelvis down low, but then you get this hypokyphosis of the thoracic spine. And that's something that is even harder to understand what's going to happen to these patients after you correct their lumbar lordosis. And I think one of the challenges is that Reha brought up as well is, you know, where do you stop? You know, how do you decrease your risks of complications? Do you have to take everybody to the top? And if you decide not to take people to the top, how is that thoracic kyphosis going to react to the lumbar changes that you do? And it's a very interesting, very academic thing as we all talk about it and think about it. Some of the things that we do sitting films. I think that helps us understand the mobility of the thoracic spine. If we're worried about it, if we're going to try to stop in the lower part, that's one way people do it. Sometimes just having people do some bending films through the thoracic spine. I tend to find those less helpful because the patient's typically in a lot of pain. But if you just let them sit, relax, and get a shot from just a single lateral, sometimes you can kind of start to understand what's going to happen with the thoracic kyphosis. And then in reality, when we talk about these standing films too, you have to make sure that that their knees are locked and their hips are extended. Otherwise, patients can look pretty good on an X-ray if you don't get a good Scoli film, and they can fool you sometimes, thinking that they're pretty well balanced, but in reality they're not at all. And then when you fuse them and you undercorrect them too much, then you can run into trouble. This is just another study looking at SVAs, pelvic tilts, lumbar lordosis, all of the things we talked about it. But as we kind of get into this, and what Reha alluded to earlier was really trying to figure out the normative values in patients as they age. And we really believe that here at Utah, and we really feel like we've decreased our issues with proximal junctional failure, as long as you don't overcorrect them. And I think that PI-LL mismatch and really trying to match that is where people get in a lot of trouble if they're not thinking about the whole spine. So this is the study that talks about that. This is sort of defining some of these normative values, and you can see as patients age, you can see their SVAs, their normal SVAs increase. And what the rule of thumb is that whatever decade you're in is what your SVA should be. So 60s, it should be 6, 70s, 7, so on. As we start to look at, other ways to address some of these compensatory mechanisms, I think this is a really good way to do it. This is the T1 pelvic angle. This is a nice way to look at patients in regard to not only their SVA, but it also takes into account pelvic tilt. So we use this T1 pelvic angle a lot. I think it's pretty easy to do, even when they're on the table as well. You don't need to be standing to get this X-ray. The one thing with the T1 pelvic angle as well, we haven't found ways to correlate it with age. But as we sort of start to think about this global tilt as well, this one we can sort of correlate with some age. This one you can see this global tilt change with age, and this is a great study looking at that. And also, as again Reha mentioned, the gap score. I think the gap score is kind of a interesting thing to think about as well. We use T1 pelvic angle and this global tilt in order to sort of address our balance issues and our prognosis for success with surgery. And I have a great case where I'll kind of go through it with us in a second. But global tilt is another measurement that that can be really helpful. As you get into some of the normative values here, you can also see this global tilt does change with age, and so you have to keep those in mind. As we get back to this case, this is like a classic case. This case started with an L3 to 5. I don't have all the X-rays. These are some smattering of X-rays that you can see that I was able to get from this patient over time. But he started with an L3 to 5. Then he developed some cervical myelopathy and ended up having an ACDF. Subsequently had some junctional kyphosis, not only at the level of the ACDF, but then distally. So then he had a posterior cervical. And then you can see that posterior cervical got extended down to the lower part of the thoracic spine. The thoracic spine failed. And then he just continued to have failure after failure after failure until he ended up eventually with this. As I started to think about this case and try to figure out exactly what to do in this situation, for me, my first thought was, obviously the title of my talk is hyper-lordotic ALIF. And so I did this probably 8 years ago, maybe when hyper-lordotic ALIFs first came out. But it's a great illustration of what the power of these hyper-lordotic ALIFs and what you can do with them. And so, I talked to the patient about that. I did not talk to them about a big osteotomy. And as you start to measure his parameters, what you can see is that his incidence is in the high 50s, his tilt is 26, so it's pretty high. His lower lumbar lordosis isn't terrible at 34, but you do want that to be 2/3 of the incidence. And so it's a little bit low. The upper lordosis, so the overall from L1 to S1 was 53, so not terrible. And then the thoracic kyphosis, obviously, for this guy is fixed. We're not going to be able to change that. And it's at 57, which is pretty appropriate. His T1 pelvic angle is 24, and his SVA is 9. And so he's very, his tilt is high, his SVA is high, his T1 pelvic angle is high. And so as you sort of think about this case and really see the change in just a hyper-lordotic ALIF, you'll be able to kind of really understand the power of this. And you can see here the change that I was able to get with just a single 20, and that was a 25-degree hyper-lordotic ALIF that we did. And then put in S1 screws and iliac fixation as well. And you can see how much better he's standing. And when you sort of compare now the new parameters, you can see his SVA is now pretty much 0. His TPA dropped to 14. His lower lumbar lordosis is 52. I think for him, because he wasn't able to sort of do anything with his thoracic spine, I tried to get a little bit more lumbar lordosis than I normally would. But you can see his overall L1 to S1 lordosis is 68. Kyphosis obviously stayed the same. And when you compare these two, you can really see this difference and how powerful these L5-S1 hyper-lordotic ALIFs are. As we sort of get into the next thing that I like to think about, and actually we had Prokopis Annis, who was our fellow 10 years ago probably. He's over in England now, but he did a lot of our early deformity research, and he came to and gave us a talk, and he really likes this global alignment proportion score. And if you can sort of correlate it with T1 pelvic angle or that global tilt, you can really understand what these patients are going to do. You can really start to understand how malaligned they are, and as you sort of look at not only the components of what this gap score is, it kind of takes everything into account. It takes the pelvic version into account, the lordosis, as well as this lordosis distribution index, which I think is very important. And then obviously this global tilt that I mentioned earlier. As you sort of look at these parameters in the scoring, and we won't go into this in detail, but this is sort of the table you use. This is where you can see the changes with the gap score. So obviously a higher score, patients do worse. But if you can get this gap score pretty low, your mechanical complications and failures are really low. And so as you sort of continue to understand these gap scores and you start to apply it to another patient, this is a young patient in their 30s who had a couple surgeries, obviously, initially for not only a scoliosis that she had as a late teen, but then she developed a distal junctional failure. She developed a non-union with broken rods. She's now coronally imbalanced. She's sagittally imbalanced. You know, if you can get away with trying to correct her without having to, you know, increase her fusion or decrease her range of motion. You know, one of the things that we will often use, and I know this is an ALIF talk, but one of the other things that we'll use is hyper-lordotic, or even just lateral cages can be really powerful in these situations as well. And one of my partners, Brian Cramian, and I do a lot of these prone laterals, and we do these together. And so this is a patient, as you start to think about this and how malaligned they are, you can see their age 33, their incidence 35, their slope is 35 there, but their lordosis is super low as well, and their global tilt you can see is 14. As you start to look at the subgroups here with this gap score, she had a gap score of 5 to start, so she was moderately disproportioned, which I think is an understatement for her looking at her standing film. She's got a lot of thoracic hypokyphosis, but this gap score kind of gives you an idea. As you start to plan what's next, we use SurgiMap to help us plan what's next. You know, and we put a couple of cages at L3-4 and 4-5. You know, we put in their what we would hope their thoracic kyphosis would do after we get this lordosis improved. And you could see is if we could achieve something like this surgically, we'd get a gap score and we'd have a nicely balanced spine with a gap score of 0. And so as you sort of think about the sort of power of the SurgiMap and planning this and having it be predictive, it's a pretty cool tool to have. And so that's what we did. You know, we did prone laterals at 3, 4, and 4, 5. We were able to get her nicely proportioned, both coronally and sagittally. We didn't have to extend her down to S1 in this young patient, and she actually is quite happy. And if you look at her scores now, she's very balanced. Gap score 0. These are the comparisons between pre and post, and you can really see the changes and the differences. One final case that I'll get into, and then hopefully we have 5-6 minutes for questions. This is a 64-year-old female. This is a patient who 10 years ago, I probably would have done something in the lower thoracic spine of the pelvis. As you can see, this patient's got a big coronal curve. She's got some pretty significant abnormalities in the sagittal plane as well. And if you measure these, you can see that you know, her PI is high 50s, her tilt is high at 30, and her lordosis is lacking. Her thoracic kyphosis is 37, which is low. TPA 14, not bad. SVA 5, not bad. And so I thought I could probably get away with something a little bit smaller. This was her stenosis. She really needed a decompression, really from 2 to 5. And you can see not only foraminally on that right side in the concavity of the curve, but then also centrally, this is her tightest level at 4-5, where that spondylolisthesis was as well. But I was thinking that if I could get some lordosis low, try to get a better lumbar distribution index, this could be super helpful for her. And then I wouldn't have to go super high either. And so I ended up stopping at L1 in this patient. We did a hyper-lordotic ALIF once again. You can see we were able to get her both coronally and sagittally balanced. And this patient also did quite well. She's about 5 years out now. And you can really see the changes in the parameters here as well. Her thoracic kyphosis increased to 50, her lower lumbar lordosis, that's actually a typo, it's 40. And her overall lumbar lordosis is now 40. So we didn't get, so all of her lordosis is happening between L4 to S1, which was also kind of a nice way to sort of achieve this with this anterior procedure. And these are the comparisons here. Again, the lower lumbar lordosis 40. And so that's hyper-lordotic ALIFs. And thank you very much.
All right. Thanks, Brandon. Great talk. Great cases too. That first case is spectacular. I mean, if you kind of quickly look at that, it almost looks like the deformity is coming from kind of the thoracic spine, and then you do a lordotic ALIF, and he's perfectly well balanced. This is pretty impressive. All right. So real quick, I think we've got three questions. First question, Brandon, I'll kind of address to you. It's this may be addressed in the talk, but any technical tips for implantation of hyper-lordotic cages? How do you know if you are pushing too far for the individual patient?
The big thing with these hyper-lordotic ALIFs, especially if you try to get too much anterior restoration, is that you can close their foramen down posteriorly. So you have to be a little bit careful with I call these hyper-lordotic ALIFs wood splitters. They're literally like a wood splitter that you put in there, and they're very powerful as you start to distract them. I try to not use this like the super high 30-degree ones. I try to put in a 20 or 25. I feel like you can get quite a bit of height restoration in that way, and then you don't close that foramen down posteriorly. And so, depending on what the patient needs, I'll kind of do that. And I think there's a question here. It's interesting, about this very specific formulas around what L4S1 should be. That is very true. Yes, you can get pretty in the weeds with numbers. I think 2/3 of PI is a pretty good rule of thumb. Obviously, you have to tailor it to every patient. Each one is different, and so. But still 2/3 is a pretty good rule of thumb.
Yeah, Adam, I would maybe answer your question with, Rousseli type 3 is going to be the most common patient we deal with, right? So very low and high PI. When you look at the means, the multi-ethnic alignment normative study that I put up on one of the slides, what you find with increased or at the extremes of PI is that lumbar lordosis from L4 to S1 stays around in the 40-degree range. And what ends up happening is if you have a high PI, your apex moves up, right, at the L3-4 level. So you're gaining more of that lumbar lordosis up higher out of necessity and vice versa. So, there is some granularity. I think at the end of the day, you pick a number that makes sense for you. I think if you pick 2/3, you're going to get it right for the vast majority of your patients, because again, most of the patients are going to be, type 3 Rousseli with kind of normative PI.
Awesome. Then the last question, I think, goes back to one of my cases. And I don't know if we have time to kind of show the case again, but you'll be able to kind of see the recording of this. So the questions, see an additional rod from the sacrum to the thoracic spine, what's its purpose, and when to apply additional rods, which side to put it on. So that was a relatively significant coronal curve. And the way I kind of think about correcting these curves is I try to kind of correct the low lumbar fractional curve first. So kind of however you do that, ALIFs, T-lifts, compression distraction, you want to basically kind of horizontalize L4-5 and L5-S1. And then I think of it as I try to pull basically the apical curve. So in that case, it was kind of a, lumbar apical curve with, reduction screws on the concave side. And at the same time, I kind of push with the rod on the convex side. So you're basically kind of pushing and pulling at the same time, pulling the concavity and pushing the convexity. And then the third, I typically put 3 rods in for all of my kind of deformity correction operations that are not involving a 3-column osteotomy. And if it has a 3-column osteotomy, I typically use 4 rods. And that rod on that one particular case, and I'm sorry I can't show it right now, is was a kickstand rod. So the kickstand rod goes on the concave side of that kind of, main curve, and you can use that kickstand rod to kind of dial in your coronal correction and get more coronal correction if you want to. It kind of prevents them also from kind of falling towards that concave side. So Ray or Brandon, I guess last two questions. Do you guys, rod wise, 3 rods for similar to what I'm doing or anything different? Just curious.
Yeah, same. I think that kickstand rod is a great way to, help with that significant concavity that occurs. I do the same thing. I fix that fractional curve first, and then everything kind of seems to fall into place a little bit easier proximally. And 4 rods for an osteotomy as well.
Yeah, for multi-level SPOs, I think it depends on if there's, a lot of anterior column reconstruction and interbody cages. I feel more comfortable with 2 rods if that's the case. If it's posterior only SPOs, I'll use 3 rods across my SPOs, and then any 3 column I'll use 4 or more, depending on the degree of instability.
Awesome. Well, that brings us to 9:01. So I want to thank everybody for tuning in, spending the time with us. Huge thanks to Ray and Brandon for 2 great talks and really great discussion. And obviously a thanks to AO North America for hosting this webinar. So hope you enjoyed it and hope everyone has a great night and a great holiday weekend.